Welcome to the debate. Today we are stripping away the preamble. We have a study that suggests we may be over-treating thousands of heart attack patients.
Right, and we have another trial suggesting that dialyzing acute kidney injury patients less often might actually help them recover faster.
And finally, we answer the question every single cardiologist gets: can patients with atrial fibrillation drink coffee?
It is a phenomenal agenda today. We are looking at high-impact, dogma-busting trials only. Let us get right into it.
Let us do it. We have 5 clinical scenarios and 5 entrenched dogmas that brand new trials from late 2025 and 2026 are completely upending. I will be presenting the clinical scenarios and the new data, representing the push for evidence-based minimalism.
I will be defending the standard of care, representing the reasonable physician approach. I am ready to defend the status quo. Let us see what you have got.
We'll start with cardiology. Scenario 1. You are discharging a patient who had a myocardial infarction 3 days ago. They have been revascularized, they're stented, and stable. Crucially, their left ventricular ejection fraction, their LVEF, is preserved. It is over 50%. They have no arrhythmias, no angina. Do you prescribe a beta blocker?
Yes, absolutely, I do. This has been a class 1 indication for decades. The logic is physiological bedrock. You want to blunt the sympathetic surge, you want to reduce myocardial oxygen demand, and prevent arrhythmias and irritable tissue. Even with a good squeeze, that heart is recovering. Sending a post-MI patient home without a beta blocker feels like malpractice.
It feels that way because the seminal trials were done in the 1980s. But medicine has changed. Enter the new data. This was Christensen and colleagues, published in the New England Journal of Medicine, November 2025.
The New England Journal of Medicine.
Okay.
Big stage.
Huge stage.
This was an individual-level meta-analysis of 5 open-label randomized trials involving almost 18,000 patients. Median age was 62, all recent MI, all preserved EF, and they specifically excluded people who had other reasons to be on the drug, like atrial fibrillation.
Right, so a pure test of the routine post-MI beta blocker. 18,000 patients is definitely enough power to find even a small benefit. What did they see?
Nothing.
Wait, nothing at all?
Absolutely nothing. Over a 3.6-year follow-up, the composite endpoint, which was death from any cause, MI, or heart failure, occurred in approximately 8% of patients in both groups. The curves were completely superimposable.
That is difficult to process. You were telling me blocking the beta receptors provided zero cardioprotection?
I suppose that makes sense. In the 80s, we didn't have stents or modern statins. The beta blocker was doing all the heavy lifting. Now, it might just be adding side effects.
Exactly. And the side effects are not trivial. We're talking fatigue, sexual dysfunction, depression, bradycardia.
So the takeaway is, if the pump is working and the rhythm is sinus, we can spare them the metoprolol.
That is exactly what the data suggests. We can likely stop reflexively adding it for preserved EF patients.
All right. That is a massive blow to the AHA and ACC guidelines, but the data sounds robust. What is next?
Let us move over to the ICU. You have a hospitalized patient with severe acute kidney injury requiring dialysis. They are oliguric, their creatinine is climbing, the patient is hemodynamically stable. Do you stick to the standard thrice-weekly schedule, or do you take a less is more approach?
Standard protocol, thrice weekly. Monday, Wednesday, Friday.
Dialysis clears toxins. In an acute setting, the kidneys are shut down. You have to replace them fully to prevent volume overload and uremia. I would assume the standard thrice-weekly schedule is vastly safer.
Replacing them fully implies aggressive management. But let us look at the Liberated D trial. This was Liu and colleagues, published in the Journal of the American Medical Association, November 2025.
The Journal of the American Medical Association this time. What was the comparison?
They took 221 hemodynamically stable patients with AKI and randomized them. One group got the standard thrice-weekly schedule. The other group got a conservative strategy.
Define conservative. Were they just withholding dialysis?
They were reactive. They only dialyzed for specific rescue triggers: severe hyperkalemia, profound acidosis,
intractable fluid overload, or distinct uremic symptoms. Otherwise, they just watched and waited.
That sounds incredibly nerve-wracking. You are just watching the BUN climb and sitting on your hands?
It feels risky, right? But here is the key result. Kidney function recovery was significantly more common in the conservative group. 64% recovered, compared to only 50% in the standard conventional group.
Wait, doing less dialysis resulted in more kidney recovery?
Yes, and time to recovery was shorter too. 2 days in the conservative group versus 8.5 days in the conventional group.
That is counterintuitive. Why would cleaning the blood delay organ recovery?
Think about the mechanism. Hemodialysis is a hemodynamically stressful event for the body. It causes rapid fluid shifts. The author suggests that these standard treatments are causing subclinical ischemic hits. You are stunning the kidneys just as they are trying to heal.
So we are essentially flogging the tired horse.
Precisely. By backing off, avoiding that hemodynamic stress, they gave the kidney the stability it needed to regenerate.
This disrupts the entire autopilot ordering of dialysis in the hospital. Hospitalists and nephrologists usually just put them on the schedule once the line is in. This implies we should be assessing daily needs rather than scheduling automatically.
It is a classic case where our help might actually be hurting recovery.
I am starting to sense a theme here today. Less really is more.
You might be right. Let us see if that theme holds up for scenario 3. Patient comes in post-cardioversion for atrial fibrillation. You just shocked them back into sinus rhythm. They ask, "Doc, do I have to give up my morning coffee?" Conventional wisdom says caffeine is pro-arrhythmic. What do you tell them?
I usually tell them to cut back or abstain entirely. Stimulants trigger palpitations, it raises catecholamines. I assume the study shows abstinence is better for preventing recurrence. Why add fuel to the fire?
Because you might be making them miserable for no reason. This is the DCAF randomized clinical trial. This was Wong and colleagues, published in the Journal of the American Medical Association, November 2025.
DCAF. Great acronym.
Very clever. They took 200 adults with persistent Afib or flutter undergoing cardioversion. They assigned one group to consume at least 1 cup of caffeinated coffee per day. The other group was assigned to total abstinence, including decaf.
Mandatory coffee versus mandatory withdrawal. Okay, I assume the coffee group had more palpitations and more AFib.
Opposite. At 6 months, documented fibrillation or flutter recurrence was significantly lower in the coffee consumption group, 47% compared with 64% in the abstinence group.
Hold on. Recurrence was lower in the people drinking the stimulant?
Significantly lower. 1 cup of coffee per day was associated with lower recurrence, not higher.
Defies basic pharmacology. How do they explain that?
2 main theories. 1, habitual caffeine might not be as pro-arrhythmic as we thought. Maybe there is an adenosine receptor antagonism effect that actually stabilizes the atrium. Or 2, think about the abstinence group. They are going through caffeine withdrawal.
That is true. Caffeine withdrawal causes headaches, irritability. It increases sympathetic tone from the stress itself. So the stress of quitting could be the trigger.
It is very possible. But regardless of the mechanism, the clinical takeaway is clear. Stop making patients miserable by banning coffee. Total reversal of common advice.
Now, a limitation there. They tested 1 cup a day, not 10 cups of espresso.
Right, moderation is key, but clearly total abstinence is not necessary.
I can get behind that. But I am currently 0 for 3 on my predictions. I need to redeem myself in the emergency room.
Let us go to the ER then. It is a busy Friday night. Alcohol withdrawal patients are piling up. Do you reach for the standard benzodiazepines like Ativan, or do you go old school with phenobarbital?
Benzos are the standard of care. Phenobarbital feels risky regarding respiratory depression. The therapeutic window is narrower. I bet benzos went on safety and efficacy.
Let us look at the efficiency data. This was Briggs and colleagues, published in Academic Emergency Medicine, November 2025.
Okay, an ER-specific journal. What did they find?
This was a retrospective study of 777 ED encounters comparing IV benzos alone, IV phenobarbital alone, or a combo. The key result? Emergency department length of stay was significantly shorter with phenobarbital alone, 5.8 hours versus 10.3 hours for benzos.
is almost double the time in the ER for the standard of care.
And the secondary result is even better. Hospital admission rates were significantly lower in the phenobarbital group, approximately 30% versus 52% for the benzo group.
So phenobarbital monotherapy led to faster discharge and fewer hospitalizations?
Yes, it is a huge efficiency play for emergency medicine.
Now, I have to flag the caveat here. Retrospective data means potential selection bias. Maybe the sicker patients got the benzos.
Fair point, and we have to acknowledge that limitation. But the signal is incredibly strong for clearing the ED, and the mechanism makes sense. Phenobarbital has a long half-life. It acts as an auto-taper.
Right. Whereas with Ativan, you are constantly chasing the tail. The drug wears off, symptoms spike, you redose. It is a roller coaster. Phenobarb just lands the plane smoothly.
Exactly. It manages the withdrawal over days without needing constant redosing.
That makes perfect physiological sense, even if it bucks the current standard. All right, what is our final trial?
Nuance alert for this last one. Chronic disease management. SGLT2 inhibitors, the Flozins. They are the darlings of medicine right now. Guidelines say use them for chronic kidney disease. But do they work if the patient has CKD without albuminuria?
The guidelines are pushing them for everyone. The mechanism restores tubuloglomerular feedback and reduces intraglomerular pressure. I assume they preserve nephrons regardless of protein spillage.
That is the assumption. But let us look at the data. This was Nguyen and colleagues, published in the Journal of the American Medical Association, November 2025.
Okay.
This was a massive meta-analysis of 10 randomized trials involving 70,000 patients. And the key result is that the benefit tracks strictly with albuminuria.
How strict?
Very. For patients with significant albuminuria, over 300 milligrams per gram, the risk difference for kidney progression was roughly 5 percentage points. Huge benefit. But for those with albumin under 200 milligrams per gram, normal albuminuria or mild, the kidney progression benefit was minimal to non-existent.
Really? So the risk reduction is driven heavily by those with significant protein in the urine?
Yes, this is a massive nuance check. If the urine albumin to creatinine ratio is normal, prescribing the SGLT2 inhibitor might not be worth the cost for kidney protection alone.
That is a crucial distinction. Now, the limitation is they may still have profound cardiac benefits. If that patient has heart failure, they still need the drug.
Absolutely. But for pure renal protection, the protein matters.
I have to say, looking back at my predictions, my standard of care instincts took a beating today.
It is time for the clinical instinct score. I am giving you a solid 2 out of 10 today. You relied heavily on dogma, the benzos, the abstinence, the routine dialysis, the beta blockers. But the data proved that less is more, or in the case of phenobarb, old school was better.
I accept the defeat. The evidence is the evidence. Which of these trials do you think changes practice the most?
For me, it is the dialysis in AKI trial, the Liberate-D study. It fundamentally changes inpatient management.
I agree entirely. The idea that our help, the aggressive dialysis, might be hurting recovery is profound. We need to question the autopilot orders.
Exactly. Whether it is scheduling dialysis, banning coffee, or prescribing beta blockers, medicine is evolving. We will leave it to the listeners to decide how quickly they adopt these minimalist approaches in their own practice.
Professional skepticism is always healthy.
That wraps up this rapid-fire edition of The Debate. We will see you next time.